Hey, good morning and welcome to UroNurse. I'm your host, Vic Sinise. Welcome to the show. We come to you every Saturday, and I mean every Saturday at 9 a.m. Central Time. And we're live on YouTube, LinkedIn, Facebook, X. We even added Instagram here today. So anywhere you're watching us live, enjoy the show. If this is your first time joining us, be sure to look at our website at uronurse.com. Best place to go to find out more information about the show. You can check out our sponsors and check out our other great podcast. Also, this is the best place to go to see all 140 of our past episodes. Yep, that's right, 140 episodes. We've been doing this for a while, so lots of episodes for you. Because of the great demand for wanting to listen in your car, we did create the audio podcast version. Every week, that right after this show goes on, about a half hour later, the audio podcast is available for you to go and check out in your favorite podcasting app like Apple Podcasts, Spotify, iHeart, Amazon Music, and YouTube Music. This week, I'm really happy to be joined by a great friend of mine and coworker, Dr. Jae Kim, who's going to be talking with me about artificial sphincters. We're going to tell you everything you need to know. Let's bring Dr. Jae Kim on to the show. Hey, Jay, how are you doing? Welcome to the show.
I'm doing very well. Glad to be here.
All righty. Just for those of you that might be new to the show, my name is Vic Sinise. As I said, I've been doing urology nursing for the past 40 years. Worked with Dr. Kim for, I can't even remember how many years. It's got to be 20, at
26.
least of those years. 26. There you go. Long time. Let's have Dr. Kim go ahead and give his introduction. Let you tell you a little about who he is and what he does.
I'm a urologist. I've been working in Chicago for almost 30 years now. My subspecialty within urology is reconstructive urology, both male and female, and I have been performing placement of an artificial urinary sphincter, management of urinary incontinence, and I'm here to provide some insight about the treatment option and something that hopefully will be educational for you.
Yeah, great. We're really glad to have you on board today. We're going to go ahead and bring up our slides here. We're going to do this as kind of a back and forth. I'm going to go through some stuff, and then Dr. Kim will comment on it and fill us in, and we'll go ahead and start talking about that right now. So let's go ahead and bring up our slide here, artificial sphincter. So this is what it looks like in case you're unfamiliar with it. That's an artificial sphincter. We're going to be primarily focusing on the treatment for male incontinence with the artificial sphincter, just to keep it in mind, but we'll do a little general information about incontinence to kind of help make sense of everything. So we're going to talk, like I said, about urinary incontinence, and is the AUS the gold standard for treating sphincter deficiency? I don't know. What do you think, Jay? Is it actually the gold standard or one of the treatments?
Well, I think that is one of the treatments available now because sphincter used to be the only treatment, especially for male patients with intrinsic sphincteric deficiency and stress incontinence. But now, for patients with a little more milder form of incontinence, there's male slings, different forms of male slings that have actually become quite useful and effective in many different patients. So I think that there are other options coming along, but right now, artificial urinary sphincter is, without any question, the most commonly used treatment option.
All right. And then we're going to talk a little about who this actually is used for. And I mentioned some things like post-prostatectomy, pelvic trauma, stress urinary incontinence, etc. For those that may not be familiar with the urinary sphincter and what it does, it's a normal sphincter function involves a coordinated muscle contraction to control urine. It basically stays tight while you're walking around and doing your normal stuff, and then opens up so you can urinate. And that's all a sphincter needs to do for a living. So let's do a quick review of the types of incontinence and whether this is a treatment option for each of those incontinence. I'm going to ask Dr. Kim. Stress incontinence, we know that's that cough, sneeze, leak. Definitely this would be one of those candidates for sphincter, I would assume, right?
For male patients, yes. And then for female patients, usually stress incontinence that involves involuntary loss of urine with coughing, sneezing, jumping, exercising is a very, very common condition in mostly postpartum patients, but even some patients who have never been pregnant before can experience incontinence with activities. So it affects women in a slightly different way and different treatment options. But yeah, it's a very common condition among both genders nowadays.
All right, good. And then we know about the urgent continence that I gotta go, where you can't control the bladder; it just fires off on itself. Would sphincter be something you'd use for that?
No, the difference between stress incontinence that we just talked about, which is a condition that's brought about by incompetent sphincter muscles that keeps us dry. Urgent continence is more due to the overactivity or involuntary spastic contractions of the bladder muscle. So underlying pathology, underlying reason for the symptoms are entirely different. So for urgent continence, there's a whole different set of treatment options that mainly target the bladder. I believe that I saw maybe a slide that you may explain the difference between stress and urgent continence. But yeah, so urgent continence is an entirely different condition that requires a different set of treatments.
Great. And then we know that there's just overflow incontinence. That's usually a bladder that's not functional. So that would definitely not be somebody who'd be a candidate for a sphincter because they're just flowing, over due to not getting the urine out.
Yeah, it's overflow incontinence would be primarily due to retention of urine. So initially, patients may not experience any incontinence, but as the bladder gets overly distended as a result of progressive retention, and the bladder will stretch and expand up to a certain point to accommodate the volume, but then once it reaches that limit, the urine will just continually drip down, and that's why the term overflow incontinence, and of course, artificial sphincter or any other surgeries for incompetent sphincters obviously would not take care of the issue. Obviously, the patient needs to be drained. It'd be helped to empty the bladder better. So, yeah, that would be the main treatment option.
And functional incontinence is when you just kind of have barriers to getting to the bathroom. Definitely not something you can treat with a sphincter. Then there's mixed incontinence. I think this does have a place. Normally, mixed is 2 or more of those different incontinence we talked about. However, generally, when we think of mixed, we kind of think of urge and stress. So I think that would be one that would also fall into that candidate. And then maybe you can talk a little bit about sphincteric deficiency. Actually, what is that?
Well, sphincteric deficiency basically refers to the status where the muscle that keeps you dry is not doing what it's supposed to do. Maybe as a result of damage, such as radiation therapy or surgery for removal of the prostate, that can cause damage to the sphincter muscle in males. But in many female patients, the sphincter deficiency may actually occur as a result of obstetric complications. Sometimes if a person has hysterectomy or any type of pelvic surgeries, that can lead to damage or weakness to the sphincter muscles. If you have hormonal changes, lack of estrogen can also lead to some weaknesses in the sphincteric mechanism for women. So this type of different conditions can damage the actual muscular component that keeps the urethra closed at rest. I mean, the muscle is what keeps you dry, basically. And so if there's weakness, then any increase in the pressure in the bladder that could push the urine may actually be able to bypass the resistance provided by the sphincter. And so that's why, improving sphincteric strength and function, or enhancing or supporting the sphincteric function with placement of a sling or the sphincter is what needs to be done to treat the incontinent episodes.
Yeah. And I think we're talking maybe mostly about men for the sphincter, artificial urinary sphincter. One of the things that we know post prostatectomy, and maybe some of our audience that's not in the professional healthcare worker, there's two sphincters normally found in a man, but after prostatectomy, they remove one of those sphincters during the procedure, correct?
Yes, it's oftentimes part of necessity during the cancer, because depending on the location of the cancer, you have to determine the extent of the excision of the tumor along with the rest of the prostate. And sometimes it's inevitable that portions of the external sphincter may actually have to be removed, with the near the apex of the prostate. And so, yeah, it's the external sphincter, that is primarily responsible for, or the damage to the external sphincter that is primarily responsible for incontinence, as well as the internal sphincter.
Yep. All right, good. Yeah, let's go on with our show. So also, can you explain the primary indication for an artificial urinary sphincter and which patients benefit most from this procedure? So who's your ideal candidate?
Well, originally, the artificial urinary sphincter was designed and invented by Dr. Brantley Scott in 1970s. He was actually a urologist at Baylor, and in the process of researching how he may treat primarily pediatric patients with spina bifida and neurogenic bladder, that was actually the initial drive for invention and perfection of this device. But then now, the primary use of the artificial urinary sphincter is primarily for male patients who have stress incontinence as a result of various conditions, most likely due to the surgery or radiation therapy for the treatment of prostate cancer. I know some patients may actually, sustain some sphincteric deficiency as a result of neurologic conditions, like even diabetes, that may cause some dysfunction. But I would say, in my experience, the vast majority of the people who requires artificial urinary sphincters are people who have incontinence due to the treatment of prostate cancer.
Yeah. I've often found it. I think women seem to be able to be put up better with incontinence. They'll wear a pad and they'll just not come in and seek help. Men, they drip a couple of little drops as they get up to do something and they're complaining. They're in the office. That kind of what you see.
Yeah, actually, there have been studies done in terms of quality of life issues after radical prostatectomy. And when you look at the factor that most significantly affects the quality of life of the patients after radical prostatectomy, has always been consistently urinary incontinence.
Yeah.
It is the factor that takes the most away from the quality of life of men with incontinence. And as a result, I can tell you for sure that the patients who are the most appreciative to the doctors after the surgery are the people who undergo anti-incontinence surgeries, like artificial urinary sphincter placement.
Yeah. Yeah. I call these game changer operations for patients. It really, like you said, quality of life goes way up. Another quick question. So, what preoperative evaluations are necessary before recommending an artificial urinary sphincter to a patient?
Well, I think that obtaining careful history and physical examination is always the foundation of the correct diagnosis. We need to, number one, obtain the history, whether there were any type of, treatment for prostate cancer with radical prostatectomy or radiation. Sometimes, patients who have prostate procedures, not for the cancer, but just enlarged prostate, conventional resection of the prostate or other procedures, unfortunately can result in damage to the sphincter. So it's not just people with cancer of the prostate, just enlarged prostate, and the treatments of enlarged prostate can lead to urinary incontinence. So you need to obtain careful history of what's been done and what's not been done in the past. And we talked about different types of incontinence earlier today, and we need to make sure that we are indeed talking about stress incontinence due to the damage to the sphincter. If a person has leakage because he's in retention, and ultrasound shows that the bladder is constantly full all the time, that's not going to be treatable with a sphincter. We also need to make sure that the patients may have urge incontinent component, but the same patients may also have stress incontinence in the cases of mixed incontinence. Mm-hmm. So it is extremely important to not mistake an urge incontinence or involuntary bladder contractions as an underlying cause of the patient's stress incontinence. So, and then the physical examination, of course, you need to be able to demonstrate that the patient, when he is standing in front of you and you ask them to cough, that there's more than just a couple drips. If there's definitely a strong urine leak with coughing efforts, I think that's definitely the most reliable objective evidence of sphincter deficiency, as long as they don't have any urinary retention. And then in some difficult cases, urodynamic study comes in very handy, because the urodynamic study will be able to tell us, based on the parameters, provide a very objective support that you're on the right track, and these patients will benefit with the proper treatment.
You do cystoscopy routinely prior to this procedure?
I think I do cystoscopy mainly because I also want to make sure that there's no strictures. Sometimes patients who have especially previous history of radical prostatectomies, you think that maybe the opening is too wide and the channel is too wide, and that's why the urine leaks. No, that has really very little to do with continence. In fact, a person could have a very tight, like pipe stem, like a rigid stricture, and yet it's always open. So the person is leaking urine all the time while there's still some obstructive component. So cystoscopy is useful to rule out that type of setting.
So I did want to mention that it's usually what we call a third line therapy. So you kind of want to put patients through some of these other things, like the first line therapy, behavioral management, pelvic floor exercises, some medications that can be used as second line therapy, especially for overactive bladder components. Are there some that are used for stress incontinence? Any drugs that you would typically try someone on?
Yeah, I think that oftentimes, the patients are, I think that actually most of the times that our surgical colleagues who perform radical prostatectomies would, tell the patients to do, very, dedicated pelvic floor exercise following the surgery. Sure. And some people do get better. So usually any surgical intervention for incontinence is usually delayed for at least a year to see how the patients respond. And then, there are some, medications, medications like Sudafed, which may actually increase the bladder outlet resistance to, manage the post-surgical stress incontinence. But I think that overall, I think most of us would agree that that hasn't really been very effective for our patient populations.
Not to mention the side effects of dry mouth and things that they have to put up with.
Yeah, and then overactive bladder symptoms definitely should be treated with anticholinergics or beta agonists. But at the same time, it will only take care of the overactive urge incontinence component, but it's not going to take care of stress incontinence.
Good. And then, again, as we mentioned, our third line therapy would be something like an artificial urinary sphincter. I'm going to have you kind of go through the surgical procedure and placement, what's involved in it, how long does it take, how many incisions, etc. So if you would mind.
Yeah, if you can then go back. Yeah, so if you look at this diagram, there are three components to the artificial urinary sphincter. One is the inflatable cuff is almost like when a person undergoes blood pressure measurement, they place the cuff, around your arm. Obviously, it's the same idea. It's this inflatable cuff goes completely circumferentially around the bulbar urethra, and it's designed to provide gentle circumferential compression of the bulbar urethra, not too tightly to the point where it may cause erosion, but just tight enough so that it could resist passage of the urine with coughing, sneezing, and normal daily physical activities. So that's the very important part of the device, the cuff. And then the pump that is placed just next to the testicle under the skin so that a person could manually squeeze the bulb right at the bottom. And that's the component that when you squeeze will push the water out of the inflatable cuff and go through the tubing and then end up in the reservoir, causing the reservoir to stretch and dilate. And that increased volume and stretching of the reservoir's elastic balloon will cause the balloon's elasticity to push back slowly the water back toward the cuff. So that's what that's what makes this whole thing work. So there are two primary ways to place these three components surgically. One is penoscrotal approach, basically making an incision at the junction of the penis and the scrotum, and then through the dissection, the cuff can be placed, the pump can be placed in the scrotum, and a second small suprapubic incision can be made to place the reservoir behind the rectus muscle in the retropubic space. But for in the past, the more commonly performed technique is actually through the perineal approach. So a person is placed in a lithotomy position, and then we make a vertical incision in the midline in the perineum. Basically, that's the area where your entire body weight would rest on if you're riding a bicycle. That's the area where we make the incision, because that incision will give us very direct access to the bulbar urethra. And then, so one vertical perineal incision and then one suprapubic incision to place the reservoir. These are all separate components that come in separately, but then once we place them in proper places, toward the end of the case, we make all the connections to the tubing so that the water will dynamically flow between different components to inflate and deflate the cuff.
About how long does the operation kind of skin to skin take?
Well, I guess it just depends on the skills and the familiarity of the team who's doing the surgery. I heard that there are some teaching places where one team is placing the reservoir through the suprapubic incision, and the second team is working on the perineal incision. But I think that on average, in average practice, maybe about an hour and a half skin to skin, perhaps.
Good. We did mention there's other procedures we had talked about a little bit. So can you discuss? Oh no, that's not the one I wanted.
Yeah, this is actually
how this compares with the male sling or bulking agents.
Yeah, this is a sling procedure. So the far left diagram is the sling for a female patient, and that's a surgery that most urologists are very familiar with. And the idea is basically the same. If you look at the middle picture, a male. I'm sorry, the far right. Sorry about that. Mm-hmm. The male sling is basically the idea is the same. You actually advance a tape of different thickness, polyurethane, tape that actually will sit under the bulbar urethra and create extrinsic compression. just enough so that it can augment the native the sphincter tone. Usually, it's this treatment is reserved for people who have much more milder form of stress
That's what I was
incontinence.
thinking.
So yeah, so somebody who doesn't, if somebody stands up and he's continually dripping, that's not a candidate for the sling procedure. Usually, if a person says, I can get by with just 1 or 2 pads a day, so it's not a huge problem, but I'd like to be even better, those would be a person for male sling procedure.
I wonder if you could discuss a little bit about your post-operative care and rehab process following the surgery. So how long does it take someone to recover? When does it start to work? Because I know it's kept deactivated when you first leave the operating room.
Yeah, we keep the sphincter deactivated for 6 weeks because, whenever you put these foreign bodies inside, they do form pseudocapsules very tightly around these components. And so what we want is the pseudocapsule that forms on the reservoir to not become restricting, in the future. So we want the reservoir to be as fully, inflated as possible. Let the pseudocapsule form, and same thing, same idea for the inflatable cuff. And then after 6 weeks, then we activate the device and let it work. So, we don't really have to do anything for first 6 weeks. The thing that we have to worry about in the post-op period is that, number one, because we are placing foreign, devices, we have to be particularly careful about the prevention of infection. And so that means that we have to make sure that the patients obtain pre and intra-operative antibiotic coverage, and we need to make sure that the patients comply with the post-op antibiotic therapy, because especially if a person has conditions like uncontrolled diabetes where their wound healing may be compromised, any dehiscence or breakdown of the suprapubic incision or perineal incision can potentially lead to the local infection, which can expand to cause infection of the devices. That would be a very unfortunate situation. Then we will have to remove all the components surgically, and going back second time is always more difficult, far more difficult than going first time. So we need to make sure that we do a good job in closing the incisions properly, but we also need to make sure that the patients follow, and that especially the perineal incision, it's an area of great tension. So I do have an experience of one person who soon after getting the sphincter placed, and he felt pretty good, so he went on a motorcycle ride with his wife for a few hours. And when he came back, superficially he had some breakdown of the perineal incision, which made me very uncomfortable and nervous about possible infection. Fortunately, it didn't happen, but yeah, so those are potential complications. And it is very important pre and post surgery to remind the patients that if they're diabetics, they really have to try their best to keep it under control. I usually tell the patients that I'm somewhat hesitant to do these type of surgeries if their HA1C is higher than 6.5. Seems like patients have more infectious complications when their diabetes is not controlled.
Now, do you place a catheter post-op?
No, that's rarely necessary.
And then as far as pain and swelling, how much should patients expect? I mean,
I think that we usually tell our patients that that they definitely should be willing to take some oral pain medications, but many patients will say, after about 4 or 5 days, pain is really not a main issue, but they're still bothered by persistent incontinence, which they have to manage for 6 weeks following the surgery.
And you kind of mentioned not to take a long motorcycle trip, but for those post-op 6 weeks till
Right.
the activation, probably shouldn't be going out to the gym either, working out and that type of thing, correct?
Yeah, I think that they should take it easy because, again, if you're sitting on a bench and doing some lifting, you're putting added pressure on your perineum. So I think that, walking, treadmill, those things are perfectly fine. But I think that anything that puts pressure on the perineum, you want to kind of avoid that.
And then let's talk a little bit about when it happens. I mean, there are some complications. We kind of talked about some infections and things you worry about, but what's the most common complication that you see with AUS implantation, and what do you do?
Well, there are some studies that have shown that the complication rates may be higher than what we think because I think that a while ago, a study from University of Michigan, Dr. McGuire, when he was the chairman there, and they were doing a lot of artificial urinary sphincters there. And also their studies actually showed that, reoperation rate was quite high among these patients. And oftentimes, the infection is one, possibility. Whenever you have a foreign body inside, there's always a higher risk of infection. And as we talked about, if a person has other comorbidities like diabetes or other conditions that can decrease a person's immunity, it can actually result in infections. Another unfortunate setting is if a person has to have a Foley catheter for whatever reason, and the caretaker is not aware of the person having an artificial urinary sphincter, he or she may try to advance a urethral catheter, which can push against a cuff that is closed, and it can cause some tear, perforation, and then that can lead to the infection of the device, which is unfortunately somewhat common. And so, we even have the wristband, just like some people have, like a medical alert, wrist braces and things like that. That can be, that can actually serve as a warning to health providers that this patient, should not have a Foley catheter placed unless the artificial urinary sphincter is deactivated, meaning, deflated. And not
There
many
it has
people
a little lock button on it so that it can stay deflated.
Yeah, even most ER doctors and most doctors don't know how to deactivate the device. So it is important that a urologist be contacted so someone can come in to deactivate it, or someone can actually provide explanation about how to do it.
So that probably brings us to our next slide, which is patient education. When the patient comes in, those are things that, you really need to stress and probably give them a handout so they have it. Like you said, maybe some kind of wristband or card so that if they have to have a catheter placed, they know to tell people, hey, I've got this device, right?
Yeah. Do you, by the way, you have this europatient.com website, right? Do you have, by any chance, the video on how to deactivate the device?
No, I don't. Actually, I have not put one up yet.
Yeah,
So
that may
that's
not be a
probably
bad idea,
thought.
actually.
Yeah.
The patients can actually do that, but usually, even if a healthcare provider can see it once or twice, then they'll know exactly, how to do that.
Yeah, kind of once you've felt it. I've deactivated them before, so I know it has a very unique click to you feel it going. Right. So when the patient comes in for that 6-week appointment, all ready to get dry again, what other things are important to stress to them besides the, in case there was an issue?
Yeah. So usually I see patients about 2 weeks, a little less than 2 weeks after the surgery to make sure that the incisions are healing fine. And then when they come back 6 weeks after the surgery, I would usually have the patients in the standing position. And depending on whether they are right-handed or left-handed, I put the scrotal pump accordingly. So the right-handed patients, I place the scrotal pump on the right side, the right lateral side of the scrotum. And we advance the device into the pouch or space that we create so that the very bottom of the scrotal pump is easily accessible right under the skin, so that if for the right-handed patients, it'll be in the inferior-most portion of the right scrotal skin, and patients can easily, reach. And using their thumb and the index finger, they can easily squeeze the very lowest part of the scrotal pump, which can, after one or two, gentle squeeze, it will basically open up the cuff completely, and the patients will be able to see very prompt drainage of urine. So that's the educational process where we do have to basically show them in person. We can't just explain or use models. We have to basically do it several times and make sure that the patients have, hand-eye coordinations, and also, make sure that the patients are able to follow the instructions. Some people who are perfectly healthy and intelligent, when it comes to these type of things, may actually have hard time, following up. So you just have to spend a lot of time and make sure that one-on-one, you're convinced that the patients are able to do it. You encourage the patient to use the device every 2-3 hours, so for the first couple days, so that you can become familiar with it. And then you usually want to have these sessions early in the morning part of the clinic. So if they have difficulty at home, they can come back to your office, so you can actually, either deactivate the device or give the patients additional help.
Yeah, it makes sense. So you start off by having the patients void kind of by the clock rather than when they get the urge. Is that correct?
That is very correct. I usually tell the patients that now that the bladder has kind of shrunken down to much smaller volume because of their chronic incontinence and the bladder not being, having have chance to expand and, store urine to its usual capacity. Most adult average bladder capacity may be around 300 or even more. So your bladder is much smaller, so you will have more frequent urge to use the washroom. But as the bladder is a very compliant organ, it will reassume its normal size pretty quickly. But for the first few weeks, they may experience a little more frequent urge to urinate, and that's good. That's so that the patients should plan on using their sphincter every 2.5-3 hours, and open up the sphincter so that you can urinate. In fact, when the patients do come back, and another potential complication that I didn't mention is that a person may experience persistent urinary incontinence, but then oftentimes it's either that they don't have stress incontinence, but now they have urge incontinence, and their bladder spasm is so strong that the urine is actually forced past the sphincter that's perfectly functioning fine. Or, I think that, opening the sphincter every 2.5-3 hours during the first few weeks is going to be critical in helping the patients to become familiar with the use of the device, and also to make sure that they're not bothered by, increased frequency and urgency with a sphincter placement.
Yeah, great. So that we know that these are mechanical devices. There's risk that it could break down and fail. So do you have any strategies on what you can do to keep this thing lasting as long as possible?
Well, I don't know if anyone has
No magic tricks.
effective magic trick, because the device is supposed to provide 24 hour, 7 days a week, continuous gentle compression and pressure. That's what it's designed to do. And then just like, as you mentioned, just like any other mechanical device, there's going to be some wear and tear effects. Usually most devices will last about 10 to 15 years. If one is able to avoid any infectious complications,
Hmm.
then I fully expect this device to go definitely 10, 15 years. However, in the past, some people may have even suggested that, well, maybe we should teach the patients to deactivate the device, every night, so that we give the patient, the urethra, some break in constant pressure, and maybe that may also allow the individual components to last longer. But there was absolutely no data, on that.
Yeah.
And so there's really nothing that I'm aware of that the patients can do or we can do to make the device last longer. Right. I think that the best thing that we can do to make the device, function longer is, number one, making sure that that the accidental Foley catheter attempt does not lead to an infection. And if a person experiences significant pain, for example, in the scrotum due to the pump, sometimes that could be due to the fact that the pump is being pushed closer and closer toward the surface of the skin. It's almost like, the pump being extruded. And even before you physically see, you may actually be able to palpate that scrotal pump may be very close to being pushed out. So before that actually happens, you may want to take the patients to the operating room and under sterile condition, maybe try to reposition it in order to prevent extrusion of the pump through the skin, because if that happens, the whole thing has to be removed. So,
and I would imagine the worst case scenario would be cuff erosion, where it's
yes, and that would be the most disappointing complication, because you have to have a high degree of suspicion, and you have to do cystoscopy to make sure that the entire length of the urethra is intact. Because if there is an erosion, then number one, obviously you have to remove the whole device. And number two, even with proper treatment and reconstruction of the urethra, there is an increased risk of stricture formation down the line.
All right. Well, this has been fantastic. I really appreciate all your information. If anybody in the audience has any questions for Dr. Kim, this is your opportunity to ask questions. I think we did a great job of covering just about everything there is. Any final words that you had about the procedure or sphincters or things that you wanted to mention?
For me?
Yeah, if you have any final words about something we didn't talk about, or I wait to see if any questions come in here.
Yeah, I think that I covered pretty much everything that I wanted to say. I think that as healthcare providers, it'd be great if it'd be not only great, but the urologists would really appreciate having nurses or colleagues who can deactivate the sphincter. Yeah. There will be some times when a physician may not be around, and having a person who is aware of and confident about deactivating a device would be great for not just the doctors, but also for the patients, because it's not very difficult to do. But I'll bet that only a very, very few nurses know how to deactivate the device.
Oh yeah, absolutely. And I mean, and this isn't probably, in urology, this is not a huge number of patients that we see that have sphincters in place. I mean, these are small numbers, but probably growing.
Yeah, I think that maybe it's a good sign that the surgical techniques regarding the treatment of prostate cancer is improving, so that more patients are able to preserve continence. But there will always be some patients. It's not the fault of the surgeons who, that some patients have post-prostatectomy urinary incontinence. It's just the nature of the disease.
Yep.
So I
all
think
cancers aren't going to be contained the same way as others. So,
right.
So I do have some comments coming in here. I'm going to bring those up here. Katie Bortel says, excellent presentation. And Neil Smith said, great presentation. A lot of good information.
Hey, Neil, I'll call you soon.
And Susie Swain does have a question here. How does a patient know if an AUS is starting to fail after, say, 10 years? Is there something they should be watching out for?
That is a very good question. Because oftentimes, if say, for example, the pump or the reservoir balloon is losing elasticity, and if the device is not functioning properly, oftentimes a person may say, now I'm having to use one pad or to remain dry throughout the day. And some patients may say, actually now I have to use 2 pads, which is more than what I used last year. And I'm okay. It's still manageable. Don't just ignore it. Just bring that issue up to your surgeon who placed the device in the first place, or talk to your urologist, because that may be a sign that the device may be becoming not as well, in terms of its competency. You may be nearing the time where either entire or parts or components of the devices may be replaced. For example, the balloon reservoir is really nothing more than a very fancy water balloon, and over time, the elasticity of the pump may be lost. So if a person has gradual recurrence but is bothered by it, sometimes you can just replace the balloon instead of changing the entire device. So if the amount of incontinence is increasing, then that's an important thing that you have to do to talk to your urologist.
Yeah, good point. I'd like to thank Susie Swain, because she's the one who wrote into me and said, hey, have you ever had anybody willing to talk about artificial urinary sphincters? And I said, I know just the guy. So, well,
that's without any question, is my most favorite surgery to do, because I do really enjoy all the positive feedback that I get from my patients.
Yeah, definitely. One of the real benefits is when you can help people out. So that's great. All right. I'm going to kick over the right one here. I got a few buttons I got to push here, but I want to give a little information about next week's show. So let's bring that up right now.
Every healthcare setting has supplies that are not disposable, from furniture to surgical instruments. All of these have particular cleaning needs. This presentation reviews types of reusable medical equipment and the cleaning needs of each type. The speaker discusses how to clean and disinfect and the disinfectants used most frequently in healthcare. The presenter also reviews the Spalding classification guide, contact time, dwell time, and how cleaning and disinfection prevent the spread of pathogens. Join us next week, April 12th at 9 a.m. Central Time for this one contact hour presentation on UroNurse.com.
Yeah, join us next week. I think this is really an important one for everybody to watch. It's good for one contact hour. Free contact hour never hurts. But it goes through all the different equipment that we have in our office that's reusable and how it should be reprocessed. It's important, for patient safety, that there's proper techniques used. And it's different depending on whether it's a blood pressure cuff or a cystoscope as to how you reprocess it. So whether you've been in urology for years and it's a good review for you, or, maybe somebody who's new to urology, this is the perfect film to watch. So join us next week for that. And Jay, again, thanks a lot for coming on the show. I really appreciate all your discussion on artificial urinary sphincters. That's been a great episode. I kind of like this back and forth dialogue with the expert. I've been doing a few of these now, and it really is a nice format. So I'd like to thank you for coming on the show.
Thank you for having me.
And with that, we'll see everybody next week.